So for the wrist and hand, we're going to start with obtaining my history. So initially, I actually want to watch how this patient walks into the athletic training room. I want to see if she is guarding her wrist, if she's kind of helping take the pressure off of it. And so once she gets to me, I'm going to ask her what happened. And so we have a gymnast that fell off of the beam, and she fell down onto her wrist with her wrist extended. And she said that she reports pain on the, where's your pain at?
Right in here.
Okay, so she reports pain right on the distal to the ulna and the medial crease of the wrist. She describes the pain as kind of dull and achy. The incident happened about 2 weeks ago, but her symptoms and pain didn't start to begin until about 2 days ago. And so she decided to come in today. So starting with just inspection, right off the bat, she was walking in, guarding it slightly, kind of keeping it up into flexion a little bit. She has slight swelling on the medial side of her wrist, more on the palmar side. And with palpation, if we start with the bony structures on the shafts of the radius and the ulna, she is negative for tender to palpate on the shaft. So now as we're getting into the wrist, I'm going to have her range of motion tested. So I want you to bring her wrist up and then down and then bring it in. So if that's for ulnar deviation, and then out for radial deviation. So her active range of motion is limited in all motions secondary to pain, but it's especially limited in extension and ulnar deviation. She can't get to full range of motion due to pain. So since she can't perform active range of motion, we're not going to perform manual muscle testing on her, but I am going to do passive range of motion, so I'm going to have her relax. Okay, and then I'm going to go into ulnar deviation, radial deviation, flexion, and extension. And so with those, again, it was limited in that range of motion, especially towards ulnar and radial deviation. And with ulnar deviation, a palpable clicking was felt. So the patient reported that about 2 days ago, the clicking sensation, and when she went into ulnar deviation, began to progress. So she's tender to palpate medial side of her wrist on the UCL, and then she's negative for tenderness on the radial styloid process and the ulnar styloid process. And then if we move up into the carpal bones, if we are over on the hamate side and the pisiform, she's a little tender to palpate, but not bad. And then down in the wrist, scaphoid is tender for palpation as well. Lunate is slightly tender, but she's nothing significant. And then TFCC itself on the palmar side right in here, that's significantly tender to the touch. RCL on the lateral side is fine. Yeah, okay, so now as a precautionary measure, I want to go ahead and just test her do a little neurological testing. So I want you to just make a fist for me. Okay, wiggle your fingers. Have you had any numbness and tingling?
No.
And she would say no. So I'm gonna go ahead and just focus on like the ulnar nerve, but we're gonna go through all of the dermatomes and myotomes. So we're gonna start, I'm gonna have you close your eyes. I'm gonna touch both sides of your face and down your arms. I want you to tell me if it feels the same on both sides. Okay? Does this feel the same?
Yes.
In here?
Yes.
Okay, right through here.
Yes.
Okay. In here?
Mm-hmm.
Down here?
Mm-hmm.
Through there?
Yep.
Put your hands out. Down the middle?
Mm-hmm.
The inside?
Mm-hmm.
And then up the inside. So all of our neurological testing, dermatomes were fine. So then I'm gonna have you shrug your shoulders. Okay, arms out to the side. Mm-hmm. Arms here. Good. Out front. So again, I'm not putting a lot of pressure on her wrist right now because I don't want to be testing her wrist, but I'm trying to get her into elbow flexion. And then go ahead and put your fingers out. Okay, squeeze in. All right, let go. Squeeze out. Good. All right, so all of her myotomes were intact as well. So we're going to go ahead and rule out any neurological pathologies that could have been related. Then we want to go ahead and next we want to rule out fractures. So a part of differentials in this is going to be possibly scaphoid fracture, distal radius fracture, distal ulna fracture. or even a hamate fracture. So we're going to just do compression on the forearm, and that's negative. We're going to do tap tests of the carpal bones. They're all negative. Okay. And then on the radial styloid process, that fracture test is negative, and it's negative on the on her side as well. Okay, so from right now, based on her mechanism and kind of what she's presenting with, I'm thinking that I'm leaning more towards TFCC tear, UCL sprain, and possibly a scapholunate or just a lunate dislocation. That's what it's calling out. Okay, so we're gonna start with some valgus tests. So valgus test tests UCL of the wrist. So we're gonna go here, and that test, it's negative for laxity, but she's got slight pain with it. If we do the TFCC compression test, so we're going to compress down on the TFCC and move patient into ulnar deviation, and that is a positive test. And so then we're going to do Watson's test to rule out a scapholunate dislocation. So for that, we're going to palpate on the scaphoid itself and then move back and forth from radial and ulnar deviation. And so that's a dislocation instability test, and that one came back negative. And so to rule out kind of the dislocations, we can do the posterior and anterior joint glides of the carpal bones and at the joint between the radius and the carpal bones. So those don't show any increased laxity, so we're gonna go ahead and rule out our dislocations from our differentials. We've ruled out fractures, and so that pretty much just leaves UCL and TFCC, and her UCL test again was negative but positive for pain, so we can associate that pain with the inflammation and tenderness coming from TFCC tear itself. What else do I have to do? Okay. So just to rule out any associated neurological symptoms, so since there's a lot of important nerves that run through the TFCC itself, we'll go ahead and do some Tinel's and Phelan's. So I'm gonna have the patient go ahead and go here, elbows down. Okay, so that's gonna be negative for carpal tunnel, and then we'll do reverse Phelan's, so bring your hands up. And that's also gonna be negative. And then if I come in here and we just do Tinel's at the wrist, that one's going to be negative as well. She might have slight uncomfortableness. That's not really a word, but it's okay. In the TFCC from Tinel's, but it's not going to be positive for neurological signs. And then so for interventions for this, our initial treatment is going to be rest and ice pretty much to help control inflammation. Once kind of we get it to subside, we'll start with active range of motion and basic isometric strengthening. And then from there, the patient will progress through strengthening exercises and range of motion, then getting into proprioception and returning back to play. Should they fail to conservative treatment, then this patient needs to seek surgical intervention.